Hello, everyone. Welcome to our webinar on sleep and Parkinson's disease. My name is Patrick Brunden, and I will be hosting this. I'd like to start by thanking our sponsors. They are Cure Parkinson's Trust in the UK, Journal of Parkinson's Disease, and Parkinson's Movement. So without them, this would not have been possible. But a very important component of our webinar is obviously our panelists in this webinar, and we have an excellent set of panelists. I'm going to introduce you to them, or they'll say who they are very briefly. I'd like to start with Dr. Sonia Matur. If you could please tell us who you are and what you do.
Hi, Patrick. Thank you for asking me to be here. It's great to see you. I'm a family physician, and I'm also a patient, having lived with Parkinson's disease since my diagnosis 21 years ago. So I know all about the challenges that this disease presents, and I work now as a patient advocate and educator.
Thank you. And then Alexander Videnovic, tell us a little bit about yourself.
Hello, everyone. It's really great to be here, and congrats on putting this webinar together. I am a neurologist. I specialize in movement disorders and sleep medicine, and I'm based in Boston at Massachusetts General Hospital and Harvard Medical School. Very glad to be here.
Thank you. Michelle Hugh, you're on another side of the planet. Tell us about yourself.
Yes, so I'm joining you from Oxford. I'm a neurologist here. I'm also a clinician neuroscientist. So my research interest is in the field of longitudinal cohorts and developing tests or biomarkers for early and prodromal Parkinson's. And my particular research interest is on people who present with REM sleep behavior disorder, and also on how sleep might affect neurodegenerative processes.
So that's great. Those are two topics we will address in the second half of this webinar. Finally, we have Gerald Holt, and we're now back in North America.
Hi, thank you for inviting me to be here today. I'm a scientist at Washington University in St. Louis, and I study the interaction between sleep and neurodegenerative disorders, most specifically actually Alzheimer's disease, tau protein.
Excellent. Thank you so much. So I can say this is really an outstanding panel we have, and they represent various aspects of what we're going to discuss. And I realize that many of you who are listening will be interested in asking questions. We know that from previous webinars we've had, and we welcome you all to post questions. I think if you look at your screen, you're likely to see a chat window to the right. If you don't see it, you may be able to turn it on by clicking the symbol for chat towards the bottom of your screen. And you can ask questions there, or you can email them directly, I think, to the Cure Parkinson's Trust, if you have not done so already. And we will do our best to answer these questions. Sometimes it's difficult to fit them in depending on where our discussion is. And sometimes we'll delay the answer 10, 20 minutes when we know it will fit into the discussion that is about to come. So we just got our first little posting from someone, so we know the chat is working, so thank you. So today we are going to discuss various aspects of sleep and Parkinson's disease. And I will just, in bullet form, explain what they're going to be, so you know if your favorite topic is coming later. We're going to discuss what sleep is from a medical standpoint very briefly at the beginning. Then we'll discuss how sleep disturbances appear in Parkinson's, what their features are, if they can be treated. And then we'll also have a discussion on whether sleep deprivation or sleep disturbances in turn affect other symptoms of Parkinson's disease, so the impact of sleep on other symptoms. Then we'll have a large part of a discussion surrounding the topic that Michelle Hugh mentioned, the notion that sleep disorders are really a predictor of neurodegenerative diseases like Parkinson's disease, and specifically this sleep disorder called REM sleep behavior disorder. And we'll talk about whether this is a chicken or the egg. Is this actually saying something's going to happen, or is it part of the pathogenic process? And then we'll go into depth into the notion that sleep disturbances are driving the disease process. So imagine that that could be one of the triggers of Parkinson's disease. That's a possibility. We'll discuss some of the molecular aspects of that. So let's kick off, and I'm going to ask Alex, what is really sleep? We sort of know what sleep is, but what is it from a medical standpoint when it comes to the brain?
Sleep is a state that is characterized by changes in brainwave activity, but not only in the brain function, but also in other physiological functions such as the heart rate and body temperature, breathing pattern. Everything changes when we fall asleep. We can think about sleep as a period of a reduced activity. We have significantly reduced responsiveness to outside stimuli, but it's also in normal health state that is very easily reversible. So we can relatively easily wake up, which is very different from some other issues when individuals are sleepy because of some other medical disorders or medical issues that they may have. And I would just close your question by mentioning that once when we fall asleep, that sleep period is characterized by transition of certain sleep stages. We go from one sleep stage to another, and two major categories of these sleep stages are so-called non-REM sleep and REM sleep. And I think that this designation and knowing a little bit about these sleep stages is going to have a particular relevance as our discussion today evolves further.
So do you want to just briefly mention what REM sleep is? There was a big band in the 90s called REM, but they took their name from the sleep form, not vice versa.
Of course. So a REM sleep, REM stands for REM sleep, REM rapid eye movements actually, and REM sleep is a stage that is characterized, it's a little bit chaotic sleep. Heart rate goes up and down, breathing pattern changes. And this is a basically stage of sleep where we dream a lot. And the frequency and duration of REM sleep intensifies and becomes faster. It becomes longer and more frequent as the night progresses, as opposed to non-REM sleep that doesn't have these rapid eye movements and that is further classified in some additional sleep stages, of which slow wave sleep is very important, as we will learn as this seminar progresses further. And that sleep is more prominent in the first half of the night that we spend sleeping.
Thank you. So what are the sleep disturbances that occur in Parkinson's disease when it's already a manifest disease? And maybe Sonia could talk a little bit about this, and we'll let the rest of you chime in as the discussion continues.
Well, Patrick, sleep should normally be a time of respite, a time to recuperate the body. Volition and consciousness are kind of suspended normally. Normally it's a time when we with Parkinson's disease actually stop moving, normally. But instead, the vast majority of us will suffer from sleep disturbance at some point during the course of our disease. And like most non-motor symptoms, sleep disturbances can really affect quality of life for patients, sometimes much more than the motor symptoms themselves. So the sleep disturbances, I'll let someone else speak to, but they can range anywhere from insomnia to movement-related sleep disorders to breathing-related sleep disorders, REM sleep behavior disorders, you mentioned, circadian rhythm changes, and so forth. So it's a really important topic for us to be addressing.
And you said that they're very common. Most people with Parkinson's have a sleep disturbance of some kind. Alex, can you give us numbers from studies on this? What are we talking about here?
Well, I think that it's overall, it's really fair to say that for the lifelong duration of Parkinson's disease, we estimated about up to 80 or even 90% of patients will experience one or the other type of a sleep disturbance, and not only disturbance during the nighttime, but the problems with staying awake during the daytime, which is that problematic excessive daytime sleepiness. It's really quite amazing that this topic came to the attention of both medical and patient community over the past maybe 30 years, although we know about the disorder for over 200 years now. It's really important to mention and discuss these topics because it is really my impression that despite the increased awareness, there is a significant underappreciation of sleep problems. They are underreported by patients and caregivers, and really underdiagnosed by healthcare professionals. So I think there is a way to improve awareness of this, and then develop some new directions how to help and address this very disabling non-motor symptom of Parkinson's disease. So I would say the majority of patients will experience a certain type of a sleep disturbance for the duration of their disease.
So is it so that the disease progression is coupled to more sleep disturbances, or are sleep disturbances very prevalent already very early in the disease? We know that REM sleep behavior disorder can precede the diagnosis, but all the other types of sleep disturbances you described, do they occur early or just late?
They may be really one of the earliest manifestations. We know about REM sleep behavior disorder, but also about excessive daytime sleepiness. And they can emerge at any type of the disease, but certainly as the disease becomes more severe and then individuals introduce a lot of different medications to treat this disease, etc., it seems that the severity and prevalence of these sleep problems try to intensify.
Thank you. So Michelle, you've unmuted. Maybe you wanted to add something to this conversation?
Yeah, so what we did actually in the UK was take advantage of the fact that we have some really well phenotyped people with early Parkinson's. And with Donald Grosset, my counterpart in Glasgow, we looked at over 2,500 people with early Parkinson's who were all diagnosed within 3 years. And what we did was to use a data-driven approach where we took everything that we were assessing people with and put it into a sort of data-driven approach to pick out features and then to see whether we could look at different subtypes of people with their early Parkinson's emerging. And we identified what we think is probably the worst subtype, which is somebody who within 3 years of their Parkinson's diagnosis has often very poor sleep. And that can be a combination of excessive daytime somnolence, sleep-wake problems like insomnia, restless leg syndrome, maybe REM sleep behavior disorder. And then hand in hand with that sleep disorder, we see quite poor psychological health. So often it's linked to depression, anxiety, maybe apathy. And then the patients in this particular subtype or cluster also tended to have worse motor disease within their baseline presentation. And what we're now doing is looking to see whether this baseline phenotype progresses differently in terms of memory and motor function. We're already seeing just over a 2 to 3 year follow-up that there are differences between the subtypes. And I think that's really relevant for people probably to know when they're in the phase of being diagnosed and being assessed in the year following. And as a clinician, the first thing I'll do if someone comes to me and says my sleep is terrible, which is sort of over 50% of people at some stage, I'll ask then I'll assess their motor state. I'll check they're not wearing off at night, because that can be a big problem for waking many people up. I'll also ask about their psychological health, and then I'll ask a bit more about their sleep history to try and understand which of these particular problems are the main issue for them.
So I'm just going to tell everybody we got our first 3 questions. I'm going to ask these questions in a couple of minutes from now, but I just want to continue on the train of thought that we started here. So people with early sleep disorders, severe sleep disorders are, as you said, the worst type. They will progress so far in your study more rapidly. So we'll discuss this later also, but do you think this is a sign that they have a different underlying molecular disease process, or do you think that their sleep disturbance in some ways driving the worsening of the motor symptoms?
So, I mean, obviously the answer is we don't know, because until we can actually identify these people very early on and actually see whether early treatment of their sleep disorder in itself modulates where they're going to be in terms of motor or cognitive progression 5 years down the line, I think we won't know that. But I suspect that it's a bit of both, actually. So I think there is actually a very exciting, unexplored therapeutic option, which is treating sleep in its own right in people with degenerative disorders, and then maybe having an open mind that this in itself might actually modify the motor or cognitive progression.
So, Alex, you have worked with studies where you've tried to treat the sleep disorder. Do you want to say a little bit about current thinking when it comes to treating sleep disorders in Parkinson's?
Sure. I really need to bring this issue that this is such a multifactorial problem, and that we see patients in our clinics, who have Parkinson's disease and other sleep problems. That's an easy 1 hour discussion in attempts to separate what really may be causing this sleep disturbance. I think important home take message for our patients and their caregivers, even more importantly, who can observe their sleep, is the fact that sleep disruption and sleep fragmentation, as patients easily fall asleep but then cannot sustain that sleep, is by far the most common problem that our patients with Parkinson's disease face. And that sleep interruption, as Michelle pointed out, can be due to many different factors. Patients may wake up and then they may have emergence of the motor symptoms, and then that can cause difficulties with turning in the bed, and they can be annoyed by that and cannot fall asleep well. We cannot forget the fact that they legitimately may have, like all of us, primary sleep disorders such as obstructive sleep apnea, etc., that may have nothing to do with the biology of the disease. Then our patients are frequently given medications that may affect sleep-wake architecture, and those are even the very same medications we used to give patients to treat Parkinson's disease. So that approach, when do we administer dopaminergic drugs to our patients, is very important. Parkinson's disease is frequently associated with anxiety and depression, and we know that these entities independently can cause interrupted sleep regardless of coexistent Parkinson's disease. So my say is that really, like a therapy for every PD patient's individualized approach to their sleep and alertness also should be individualized. And we really need to consider all of these very broad spectrum and etiologies that can, and reasons that can lead to that impaired sleep. And that's very important because that approach will lead us to really the correct treatment approach to each of our patients who experience sleep problems. Now, I mentioned some of these causes that are relatively easily identifiable. Even the focus of the talk today will wind down to the fact, what is the role of the primary process that drives the biology of Parkinson's disease, and whether that neurodegenerative process itself can cause issues with impaired sleep and alertness. And we really are very comfortable today saying that that's the case, because we know that the pathological changes in the brain structures are present in these centers that are very important for the regulation of sleep and alertness. And it's undoubtedly that primary process that drives this Parkinson's disease is certainly causing sleep interruption. The trick is here, how do we approach those patients in whom the majority of the issues with sleep are related to that primary neurodegeneration of these brain centers that are affected by spread of these pathological proteins associated with Parkinson's disease. And we talk a little bit about sleep, but I want to introduce this other concept to our audience, and this is the concept of this timing system, which we call the circadian system, which is kind of very relevant for all physiology and human behavior as well. We all have this timer, our clock in our brain, that really times all bodily functions, including sleep and alertness. And there is a really emerging evidence, not only in Parkinson's disease, but other neurodegenerative diseases, that this internal clock, this circadian system, may also be malfunctioning. And that part is, of the brain is really critical for sleep consolidation as well. So we are really looking at really some nice, unique opportunities and directions where we can learn a little bit more how is this sleep disorganized and what we can do to treat it. So you asked me how we treat these sleep disorders, and this was a kind of long-winded answer. It is really individualized, and one must detect the cause of this sleep disruption and then take a unique approach and target intervention to that specific cause.
But it's fair to say that treatment of sleep disorder in Parkinson's is lagging behind when it compared to treatment of the motor dysfunction. Because of the history of the disease, sleep disorder was only recently recognized as a major issue, and it is labeled as a movement disorder. So the focus of the medical community has been on the movement.
Yes, that is exactly correct. But I think that we have also made great advances in embracing sleep dysfunction, and the REM sleep behavior disorder really is a great example why sleep is so critical for our patients with Parkinson's disease. But I would also like to validate what you've just said, that we are really lacking well organized evidence-based medicine clinical trials that have examined interventions to treat sleep disorders in Parkinson's disease. And hopefully we will see more and more of clinical trials in partnership not only with academia, but with our industry colleagues in the pharma industry. And I see some notion of moving in that direction, that there is more and more interest to formally study interventions that are aimed to improve sleep and alertness in PD.
So, Michelle, we had a question that actually touches the circadian rhythm. And specifically, this person, Massimo, is asking us whether there's a relationship between REM sleep behavior disorder and disruption of circadian rhythm.
So there haven't been many studies, as far as I know, that have really looked properly at circadian rhythm in RBD. However, there has been a number of studies that have looked at it in Parkinson's. And what they have found, this is a study I'm thinking of by Roger Barker, that looked at people who had roughly had about 5 to 7 years of their Parkinson's diagnosis and disease duration, so moderately severe. And there was quite universally in those individuals quite marked changes to suggest that the circadian rhythm was started to be very affected. So the melatonin that was produced by these individuals in the 24-hour cycle was reduced, and they also had formal sleep studies, and they had really marked sleep fragmentation. They weren't very sleep efficient. So sleep efficiency is just the proportion of time you spend in bed asleep. And that really went down. And interestingly, a number of patients, as their Parkinson's progressed, their proportion of time spent in REM sleep actually reduced. And they described 2 people that had no REM sleep whatsoever that was recordable during the overnight sleep studies. Alex, are you aware of any sort of proper studies that have looked at circadian rhythmicity and RBD? So, I mean, properly, you know, both biochemically, sleep study-wise, and perhaps using a wrist actigraph to just sort of look at the 24-hour cycle.
Well, thank you, Michelle. You know, Roger did a very nice study that you just referred, and that was in relatively early patients with Parkinson's disease. We did a similar study in more advanced patients with Parkinson's disease and have demonstrated that the amplitude or the strength of that circadian signal is quite dampened in patients with Parkinson's disease. Then we look at the de novo patients who were untreated with Parkinson's medicines and have shown some dampening, which was not as prominent. And currently, actually, we are undergoing a study supported by National Institutes of Health, which is really looking at the circadian rhythmicity in patients with REM behavior disorder under these circadian-driven protocols, because in order to isolate that circadian signal, one needs to put individuals kind of in darkness and control really strictly their environment. So we are looking at that study, and what's interesting, I think, and Professor Barker demonstrated that maybe there is evidence that even the clock genes that are regulating circadian rhythmicity on molecular level may have some impaired circadian expression over the 24-hour period. And there is increasing evidence that these very genes may be very relevant for modulation of a neurodegeneration, not only in Parkinson's disease, but other neurodegenerative diseases such as Alzheimer's disease and other movement disorders. So I will leave it at this.
Yeah, I mean, I think the other thing just to comment is that if you ask somebody to fill in a sleep diary, it's quite subjective, and people who can't sleep always overestimate the amount of time that they actually think that they're spending awake and not sleeping. So really some form of wearable to kind of measure this, whether it's just literally a wrist-based activity or a more formal sleep, is really important. And the other thing that's been shown is...
Could I just interrupt you there, Michelle, because we just got a question from somebody called Ricky Lay saying, do you feel that Fitbit sleep records are accurate enough to consider as a credible insight on sleep?
So again, I think it really depends on what you're actually hoping to get. So, I mean, I would obviously, Alex is more of a sleep expert than me, but I think what that will do is really give you an idea of activity in a 25-hour cycle, but it's not going to distinguish if you're lying quietly in bed, awake, from actually being asleep. So it's only when you have brain rhythm, EEG recording, that you can really actually know where you distinguish from light sleep to wake states, and also distinguish that from REM sleep. So many sleep neurologists would argue that you really need more than just a Fitbit, which is simply movement activity.
So it's funny that this question came today because yesterday our family received a letter from somebody who's going to pursue a lawsuit against Fitbit because they have said that you can track sleep. And since we purchased a couple of Fitbits, they're mailing this out to everyone saying, do you want to join this lawsuit? I don't know if that has any credibility at all, but we get those letters if you live in the US sometimes about various things that you purchase that aren't good, according to the lawyers. So let me just slightly switch topics very briefly and ask about multiple system atrophy. We had a specific question there, and I think you can give a simple, short answer to that. Is MSA also associated with sleep problems?
So I do a large MSA clinic. I have maybe about 150 to 100 people with MSA and other forms. I would certainly say that MSA patients get REM sleep behavior disorder, but I think it's probably a bit less common than in Parkinson's. And they can also have things like daytime somnolence and all of the kind of circadian rhythmicity issues that people with Parkinson's get as well. And of course, other degenerative conditions like dementia with Lewy bodies will also experience RBD. And of course, if you see somebody with a predominant memory issue who has RBD, the chances are that they're actually most likely to have dementia with Lewy body as their presentation.
Are people with early onset Parkinson's disease, this is another question from our listeners, are they more prone to worsening of sleep disorders, rapid worsening?
So, I mean, there have been very few polysomnographic studies that have properly looked at this. The ones that I have mentioned have generally found about 30 to 40% of early Parkinson patients have proper evidence of REM sleep behavior disorder. Also that's also been shown in early untreated patients. In our cohort, what we've done is look at it with a questionnaire, which is nowhere near as accurate. And we found similar prevalence in early PD. Roughly 40% have either excessive daytime somnolence or RBD. But the question being posed is, how does it change over time longitudinally? And we're just embarking on a study here to track sleep in 50 people with RBD over time. So we're studying their sleep every 6 months in their own home with sleep wearables. The same with 50 Parkinson's and 50 controls. So I think there hasn't been much longitudinal sleep studies, but we will be able to get that data in the next few years.
And Alex, there's a question for you. It's a question we often get in webinars and fora like this. It's do alternative therapies such as cannabis oil help sleep patterns in Parkinson's? And in the US, of course, the medicinal use of cannabis is legal in many states. So what's your experience there? Not your personal one, but your clinical experience.
Sure. So I'm going to be very direct and say that I do not have a lot of experience with this. I consider myself, and I'm going to honestly admit it, poorly educated when it comes to use of cannabis for sleep indication or in general for Parkinson's disease indications. I think we have to learn more. I am going to say that I am not ready to dismiss this as some potentially viable and useful intervention. And I will say that I have a number of my patients who have used some of these preparations. Most of them come and tell me that they put a couple of these drops of various oils that they can find on the market, that improves their sleep and that improves their anxiety levels, etc. Certainly, we do not have studies that have examined use of cannabis for sleep, in Parkinson's disease. Do I think it's worthwhile researching? I really strongly believe so. I think we are early in the stages of this compound and use for Parkinson's and for other neurological diseases. So I have to leave it at this. I myself need to educate myself more about it, and I have not been using it widely in my patients at all yet.
Okay, thank you. So I think we're going to switch gears a little bit. So just to summarize, for the first half hour, we've talked about sleep disorders being very common in Parkinson's disease and severe sleep disorders being associated perhaps with more rapid progression of disease. And we've touched very briefly on the topic that the sleep disorder itself could be involved in the disease process, and also that the primary disease process related to motor dysfunction may also in some way influence the sleep disorder. But I'd like now to think a little bit more along the lines of variations in sleep pattern, because of course patients don't have exactly the same sleep issues all the time. How do they affect their daily lives? The next day after a poor night of sleep, how does a patient do? Maybe Sonia, you want to talk about this, and perhaps we could relate it broadly, not just to motor symptoms and the classical non-motor symptoms, but also talk about dyskinesias, for example.
Sure. Our disease management is really quite a fine balance, not only with our medications, but other lifestyle factors such as diet, exercise, stress, and sleep. So when one of those factors is impacted, it really does affect patients on a sort of global basis. It, as you mentioned, affects our motor symptoms. It can affect our non-motor symptoms such as pain and cognition and mood. And it also can decrease the effectiveness of our medications that day. Most of us will find that we're more symptomatic than we normally are given the same amount of medications. And the dyskinesias can also be quite significant afterwards. And this is really kind of a vicious cycle because the PD is causing the sleep disorder and the poor sleep is aggravating the PD symptoms. So it becomes this really vicious cycle that has to be broken at some point. So it is very impactful on quality of life for patients having this issue with sleep.
We had a very specific question. That was a very good answer, but there's a very specific question here from David Weston. He says, does lack of sleep aggravate hallucinations? And as you know, hallucinations are more associated with advanced disease and the actual drug therapy. Sonia, anyone else want to chime in here? What's known about this?
I don't know of any studies. I don't know if anyone else does.
Michelle, Alex?
We really do not have answer to that specific question. We know that continuity and duration of sleep is very important for overall brain health. And we know that it is very possible that when patients go into the cycle of several nights of several sleepless nights, that threshold for them having all sorts of negative effects, as Sonia mentioned, increases, and it is therefore likely that hallucinatory behaviors may certainly be modulated by sleep and by insufficient sleep. It, however, has not been formally studied.
All right, so I'm going to switch gears again now, and we're going to move more into the realms of REM sleep behavior disorder. And you heard briefly what this is earlier in our webinar, and perhaps we can define it once again, but I want the panel to discuss whether REM sleep behavior disorder is the chicken or the egg. And perhaps, Michelle, you want to kick this off, and I would expect Jerry might want to chime in here too, and when we try to understand what happens at the molecular level in the brains of mice and presumably humans as we sleep. But Michelle, tell us again about the REM sleep behavior disorder and its relationship to Parkinson's disease and other closely related neurodegenerative disorders.
So REM sleep behavior disorders is a parasomnia, and what happens is that the normal paralysis of our
parasomnia, body, Michelle?
A type of sleep disorder, basically, and it happens that the normal paralysis of movement that happens when we dream is lost, And this is because a circuit in the brainstem is affected, commonly in the case of degenerative conditions, by neurodegeneration. But of course, we can see it in other things like a stroke or inflammation in somebody with multiple sclerosis who might have a plaque just in this important area of the brainstem. So typically when we dream, big movements, particularly arms, leg and trunk, are suppressed. Our eyes might flicker and we might have a little bit of movement around our trunk, but we don't act our dreams. So particularly with REM sleep behavior disorder, the dreams that people get tend to be much more vivid. They're often quite frightening, often recurrent nightmares. And so the type of activities that happen are people will shout or talk and they'll move. They'll often enact out their dreams. So somebody who thinks his wife is being attacked will hold her and punch repeatedly who they think the attacker is, or they'll be dreaming that they're scoring a goal and they'll kick their foot and hit the radiator and wake themselves up. Many people are totally unaware that they're doing this, and it's the bed partner that is very upset because they're woken up repeatedly, and it's often quite injuring type of behaviors. Black eyes, not uncommon. The worst case that I have had very sadly is of a lady who had MSA, who knocked her eye on the corner of her bedside locker, detached her retina and then went blind. So had not only the MSA to deal with, but actually loss of vision in one eye completely. So, you know, episodes of RBD in themselves have comorbidities. They have, you know, they have big sequelae. I became interested in this because I followed up a patient of mine who presented with what appeared to be a very typical REM sleep behavior disorder, which was responded very well to standard treatment, but came back 2 years later. And when I'd examined him before, he'd been completely fine, motorically, but he came back with a 6-week history of arm tremor, difficulty handwriting, and indeed had an early diagnosis of Parkinson's. REM sleep behavior disorder is such a new condition. It was, in fact, only described by Carlos Schenk in 1986. So it's about 30 years old. And really, it was due to pioneers like Carlos and others who followed up these people with RBD that we now recognize up to 80% of them will convert. And the conditions that they convert to are all protein misfolding. And the protein that's misfolded is alpha-synuclein, which we see in Parkinson's. About a third of people convert to PD, but a third also convert from RBD to another alpha-synuclein disorder, which is dementia with Lewy bodies, and a third also to other mixtures like multiple system atrophy and autonomic failure. The latest
Could I just ask there, is there any hint, the nature of the RBD, are there features in the RBD that will predict whether you're going towards Parkinson's disease or dementia with Lewy bodies?
Yeah, so that's a really interesting question. To try and answer this, Ron Postuma very heroically collated data from 24 plus sleep centers and looked at all of these people with RBD, and they followed up 1,240. So Alex, I think, contributed cases from where you are. We contributed from Oxford. And it seemed that the biggest predictor of whether you went from RBD to dementia with Lewy body was your global cognitive function assessed with a Montreal Cognitive Assessment. So a reduced MoCA score predicts that you're more likely to go from RBD to dementia with Lewy body. And the biggest predictor for converting to Parkinson's is motor dysfunction. We've seen that in our own cohort. We have about 240 people now. We've only followed them up over 3 years with their RBD. But if you just look at them, you see already subtle motor problems. And these are sufficient that they are separate from people who are control subjects, the same age, the same gender. So there's already significant differences in these RBD patients. If you look for anxiety, if you look for depression, if you look for cognitive impairments, they're already there. And interestingly, they're on a similar rate of severity to those with early Parkinson's. So the main thing that really discriminates people with RBD from early Parkinson's is really the severity of their motor impairment. So it may be something very subtle, like when they walk, they might not swing one arm. They may have very, very subtle rigidity or maybe a little bit of postural tremor, but it's certainly not sufficient to say you've got Parkinson's, you need treatment. But it would be enough to say you haven't, you know, you're not a control person, somebody who really is just a normal aging person.
So it's quite stunning. We're 202 years after James Parkinson wrote his essay on the shaking palsy, and the link to REM sleep behavior disorder, you said, I think it's 30 years. I wonder if it wasn't even 96, not 86.
Yeah,
I don't think I'd ever correct you on anything, but I just looked it up.
Yeah.
But it's just amazing that this has been missed and the link hasn't been made. And I think the numbers that you present and that are coming from various studies are striking, that if you live for 15 years from being diagnosed with REM sleep behavior disorder, 9 out of 10 of those people will have a neurodegenerative disease.
Yes.
It's quite
and having sort of personally followed up people, you know, the overall rate of conversion in our cohort in Oxford is very similar to the combined data from Ron, it's 6% per year. So, you know, in the 3 years that we followed up people, over 22 now have already converted, which is bang on 12% of our original 240 people. And it is very sad, actually, and it sort of begs the question about when should we be considering intervention with potential treatments that might actually not just sort of slow down their progression from RBD to Parkinson's, but might even mean they don't get it at all, might prevent it altogether, or might mean when they do convert, they get a milder form of Parkinson's.
Yeah, so we're going to come to that, the idea that RBD, people with RBD might be the ideal candidates for potentially neuroprotective therapies. We'll talk about that in a minute. So I had a question. We're going to ask a question from one of our listeners. How does restless leg syndrome fit into the REM sleep behavior disorder? Are they linked? Maybe you want to say what restless leg syndrome is. I was going to ask Alex first.
Yeah, sure, of course. You know, so the short answer is really that we really do not have links between pathophysiology or even manifestations of REM sleep behavior disorder and restless leg syndrome. Restless leg syndrome is belongs to a group of sleep disorders that we call movement disorders of sleep. It is a sleep disorder which is very prevalent in general population, and it's associated with this sensation of restlessness, usually in the legs, in lower extremities, that has a strong diurnal preference and appears in the evening hours when we want to relax and sit down, talk to our family or enjoy some TV shows, etc. And then our legs really start to feel very funny. It becomes very uncomfortable sensation that is associated with urge to move. So due to these intense sensations, we need to get up, walk around a little bit, and that usually is associated with significant alleviation of these symptoms. We feel much better. But as soon as we resume that sedentary position, certainly these symptoms may emerge. So that is a very different behavior than behavior that we have in a REM sleep behavior disorder when one is fully asleep and starts to act these dreams. We don't have evidence that these two are linked. But I want to mention, since we are talking about sleep in Parkinson's disease, that I believe that almost every patient who comes to my clinic says, I have a restless legs. I think, you know, that in the general public, individuals are overdiagnosing themselves with restless leg syndrome, especially patients with Parkinson's disease. And I'm saying this because there are so many mimics of restless legs phenotype among patients with Parkinson's disease that may actually be due to not restless legs, but to Parkinson's disease itself. There is this phenomenon of akathisia or inner restlessness that a lot of patients with Parkinson's disease have, that certainly upon description, or if one sees a commercial for restless legs, can look like they're just exactly like restless leg syndrome. Then patients with Parkinson's disease may also have some stiffness and rigidity that can worsen with a prolonged period of sedentary position, etc. So it is really important, if you believe that you have restless legs, to carefully diagnose it with your provider. And of course, the situations when we talk about restless legs and Parkinson's disease is further complicated by the fact that restless legs syndrome is going to be treated by the very same medications that we use for the treatment of Parkinson's disease. And hence the relationship of restless legs and Parkinson's disease is a really complex one, but we cannot—
poorly understood, right? We really
don't—
we can't say we understand it, right?
Yes, of course.
It's very enigmatic that one condition that involves the willingness and urge to move is associated with treatment of a disease where you can't move. But you mentioned something that's important. You know, the people may perceive that they have restless leg syndrome. It could be something else. Isn't it also the same with RBD? And we had a question from a listener saying, can you discuss what the cutoffs are for clinical REM sleep behavior disorder? And are there people, maybe I can ask Sonia, in the PWP community, where now when they're beginning to hear about the association with RBD and Parkinson's, are people beginning to think, oh, maybe I did have RBD 5 years ago or 10 years ago? And it's a clinical diagnosis that requires more than an anecdote from the spouse, right?
Yes, I mean, I think we all look back and can see pre-disease diagnosis symptoms that we can relate to. I haven't heard specifically about RBD being an issue for most people who I know have known that they had RBD before their diagnosis. And that might be, again, anecdotally as opposed to clinically. But I think we all sort of look back and in hindsight can sort of see a lot of symptoms that we may have been experiencing.
So it's a very exciting topic, and it has another feature which Michelle touched upon, the idea that perhaps one could treat the underlying neurodegeneration much earlier by identifying people with RBD. And whilst you're on the microphone, Sonia, I'd like to ask you, what is the perception in the community about this, that the research focus now is shifting towards earlier and earlier disease? And I know people say, well, what about us? Those of us who've had the disease for 10 years, will we ever benefit from research that is focused on people that don't even have the disease yet? They're in this prodromal state.
And I understand that. I'm 21 years into this. So for myself and others like me, the early detection is not necessarily going to benefit us. We've been on this journey for a number of years. But it will help those in the future from embarking on this journey in the first place. But that's not to say that it won't help us indirectly. I think that any research yields more information, gives us a greater understanding of the disease. So if we're able to sort of see what the pathological process is that takes a person from RBD to one of the like either Parkinson's disease or MSA or the Lewy body dementia, I think that piece of information is very important overall to our understanding of the disease, which will ultimately benefit us as well.
So I think that's a very good way of reasoning about this. And it's also a good way to start the last part of our webinar, where I'd like Jera to tell us a little bit about what she's been doing in relation to Parkinson's, with the background that Jera has looked at proteins that are typically associated with Alzheimer's, but also with Parkinson's, and a little bit on the protein called alpha-synuclein, which I think many of our listeners know is the primary protein component of Lewy bodies that are prevalent in Parkinson's disease and Lewy body dementia. But the fascinating notion that the levels of these proteins are somehow regulated by sleep patterns. Tell us about this, Jared, because it's very, very important.
Yes, so the relationship between sleep and these proteins more specifically can really help us gain insight into how sleep may affect how the diseases progress. And as you said, most of my work has really been focused on Alzheimer's disease proteins, tau, or also A-beta, where we've done some more sleep studies looking at these proteins in the brain. So inside mouse brain fluid, as well as in human CSF. And in these proteins, we see that neuronal activity can increase secretion of tau and A-beta. And sleep can increase metabolism and synaptic strength. And we've shown that in the AD, both A-beta and tau, that simply sleep and wake can regulate the secretion of these proteins into the interstitial fluids and the cerebrospinal fluids. And so we see this fluctuation with sleep and wake, and also importantly, with sleep deprivation in both mice and humans, we see an elevation in these proteins in these fluids. And recently, while looking at tau protein, we also looked at alpha-synuclein in cerebrospinal fluid of humans who had had 1 night of sleep deprivation. And compared to a night of normal sleep, they had elevations in alpha-synuclein with sleep deprivation, very similar to what we saw with tau and A beta. So this suggests that alpha-synuclein could be regulated similarly to tau and amyloid beta, which we know much more about. And we also know, although there's not been tons of research on this, we do know that alpha-synuclein in mice is secreted into the interstitial fluid with neuronal activity, just like we see with tau and A beta as well.
Where does it go from there? Once it's in the interstitial fluid or in the cerebrospinal fluid, where does it go?
There's still a lot of research on that. I'm not sure, we don't truly know that. Some of the, like amyloid beta has been more thoroughly studied, and they've identified a lot of transporters that help clear A beta from the brain through the blood-brain barrier. Of current interest to people interested in sleeps is something called the glymphatic system. And this is a method of clearing proteins, metabolites from the interstitial fluid through the CSF. And that is very interesting to sleep researchers right now, because this flow out of the fluid of the brain has been shown to increase with sleep. So I think it's about 2-fold greater during sleep than compared to wake. So they suggest that this clearance of metabolites and things like alpha-synuclein, tau, A beta, these neurodegenerative peptides that can aggregate, could actually be increased during sleep. So if you have less sleep, could this possibly lead to some propagation of disease? That becomes the next question that with alpha-synuclein, that has not been studied yet.
Do you know if anybody's studied the levels of these proteins in the cerebrospinal fluid of people with RBD? Because you looked, I understand, acutely at people who were sleep deprived.
Yes, I am not familiar with any research that has looked at that, people with RBD. I have seen studies looking at it in preclinical and clinical AD cohorts, but I'm not sure with RBD.
And I wonder for the whole panel, does anybody know, and I don't have an answer to this question, if people who work for decades in jobs where they have night shifts or they fly airlines across time zones, is there any epidemiology to hint that there is an increased risk of neurodegenerative disease in these populations where the sleep disturbance is forced upon them by their work?
So I can comment on that. There are a few epidemiological studies that have looked at the incidence of or risk of development of Parkinson's disease in shift workers, and the studies have shown kind of opposite results. So more work is needed in that area. There is some evidence, interesting evidence, that geographic regions with the various environmental light presence have been a little bit more protective in terms of prevalence of Parkinson's disease in these populations. And both of these elements are kind of being a reasonable link with these hypotheses of circadian disruption that may affect Parkinson's disease and vice versa. So, and I think, this is something that would be relatively easy to look at because there are large epidemiological cohort studies of shift workers. And the question is just whether this diagnosis was ascertained and reported, but certainly something that should be worthwhile looking at, because we know strong effects on cancer, for example, breast cancer, et cetera, among nurses with the nursing health study, et cetera. So I think that we should take similar approach and look at what happens with neurodegeneration and Parkinson's disease.
So I'm going to get back to the point of treatment early in disease and what these mechanisms that we just heard from Jera might mean for treatments. But before then, I have a question from a listener, Ruben Jessup, maybe Michelle wants to answer this one. Do RBD patients sleepwalk, or are the movements typically confined to the immediate area of the bed?
Yeah, so that's a really interesting question. They don't tend to sleepwalk, mainly because their movements are actually not very good for anti-gravity. So most people with RBD, when they're lashing in the bed, don't actually manage to stand. They'll fall out of bed and wake themselves up when they hit the floor or the radiator. So this is really different from what we call the non-REM parasomnias, which happen in non-dreaming sleep, when people, particularly younger children, will sleepwalk very effectively. But there is some very interesting evidence why people have looked at the quality of the movement with people with Parkinson's when they dream, and also during RBD, and the movements seem to be better. The quality of the movement, interestingly, seems to be smoother. The tremor often disappears during their sleep. And it's quite interesting to sort of speculate whether there are different movement pathways that are being accessed in the brain during that. A bit like paradoxical movement that we might see, where somebody can suddenly go from being completely off and very, very stiff and unable to move and just get out the door because somebody's yelled fire. So, you know, it's quite interesting how movements can change. I wanted to say we're also looking at alpha-synuclein in the spinal fluid in our cohort. So we have a new way to look at it using an RT quick assay. And in our first 5 people with RBD,
we have to explain what that is, Michelle. It's a fancy biochemical method.
The fancy method that shakes the spinal fluid for 36 hours. And it was initially developed to diagnose prion protein, which has this abnormal pathological seeding reaction that happens after about 3 days of this aggregation. And it's to do with this stickiness of the alpha-synuclein protein that makes it do that. We found 3 out of 5 of our first RBD patients' spinal fluid was positive for alpha-synuclein on this assay. And we're now, with colleagues like Alex from the international RBD group, looking at it in a much larger data set.
That's very, very interesting. Now, you mentioned night frights in kids and kids sleepwalking, and I think we're going to get a question if we don't have it already. Is that in any way related to RBD? My understanding is no. Am I right?
No, I think I would agree with that. I'm not aware of any link. But there is, interestingly, you were asking about shift workers, and sort of another interesting group to look at are people with obstructive sleep apnea. So these are people who snore very loudly, and due to that respiratory obstruction in sleep, they will have periods where their oxygen saturation dips, and as a result, they'll kind of go and wake themselves up. So they'll have what's called a confusional arousal. And this may be happening multiple times, so their sleep pattern is very disruptive. And there's been a study published recently which followed up 2,000 people in Taiwan with this obstructive sleep apnea, comparing them to 9,000 matched controls, and found that the incidence of Parkinson's was much higher. It was actually double that compared to the same group of people without the sleep problem, same age, same gender. So that would suggest that the hypothesis that sleep disruption in itself might trigger or accelerate neurodegeneration.
So we are almost out of time. I'd just like to close with a very short question to Jara. Everybody should realize Jara had a paper in Science, which is a very prestigious scientific journal, just 6 weeks ago. And it was a very fascinating paper. It's what you described. But do you, in one sentence, think that there might be a therapy coming out of the sort of research you're doing, suggesting that sleep patterns regulate these proteins associated with Alzheimer's and Parkinson's?
I believe there's definitely intervention areas for sleep in both Alzheimer's disease, other neurodegenerative disorders like Parkinson's. It's definitely a therapeutic area that we haven't touched upon quite enough. But I think as we learn more about the sleep disorders that occur across these diseases and in patients, it definitely opens up areas for intervention and disease spreading possibly in the future.
So that gives us some hope. I think this has been a really fascinating webinar. Maybe I'm biased, but it is an emerging area of science. And I'm sure we're going to return to this topic because Parkinson's disease is so much more complicated than the movement disorder. that is associated with it, and perhaps our understanding of the origins of the disease lie in things such as sleep and gut function. And these are areas that, of course, we want to highlight in these webinars. I'm very grateful to all the questions we've had and to our panelists. Sonia, thank you very much. Jara, Michelle, Alexander, all of you have been really great. And also thank you to the sponsors, which is the Cure Parkinson's Trust, Journal of Parkinson's Disease, and Parkinson's Movement. We will be back in about 3 months from now. We'll let you know what the topic is going to be. It's to be decided, but we have some ideas, but it's sure to be an exciting one, that I can promise. And if there are questions we didn't have time to answer, we'll do our best to do this via email, or perhaps there'll be another forum on the Cure Parkinson's Trust website where some of these questions can be highlighted. But thank you everybody for joining us, and we'll be back in a few months from now.